So I want to start, and I know there are hands going up and mics, but I want to start with just one question before I turn it over to you all. So I want to sort of turn to the consumer perspective and some of what we have heard about some, earlier we heard about there's sort of a bad story cycle per 7 days or so that we sort of all fixate on for a little bit and we move on. But I think that I want to raise two possible issues and hear from you whether you think these are kind of ephemeral, they're just going to settle out after this open enrollment period, or if they're maybe going to come back in a different form next year. And recognizing everybody's heads down with this year, I want to invite you to think out into that future period a little bit more. So the two issues that I want to ask you about, and I'm going to sort of, one's a little bit more on the public side and one's a little bit more on the private side, so I'll ask you to sort of split up that way. On the public side, the enrollment numbers are really impressive, and CHCF has some focus groups going on now looking at enrollment stuff, and absolutely you see people who are so happy. They moved through the process, they got through Medi-Cal, they were electronically verified, they got their card, they've seen a doctor, and it's February, for heaven's sake. I mean, there are some good news stories. But there are also some stories of people who didn't, for whatever reason, get through that in the seamless way. They're stuck somewhere, they're confused by paper. There are stories on both sides. So the question, I think, is, are we going to be in a more streamlined, it's working for 90%, versus 10%? Are we going to stay kind of in there are a lot of ups and downs, and it really depends on your circumstances. So is that going to be an issue that sort of resolves, we move on, we're in a good place in a year or not? So let me start with that one for probably Toby and David, and what you see as, the continuing challenges, but also the continuing opportunities, I think, to make this, as you said, Toby, not your grandmother's Medi-Cal.
Yeah, I mean, I think David and I will see if we're on the same page. It's going to, 2014 on the IT system, it's going to continue to be challenges. We're, going through, I mean, we took a system that would, under normal case, we wouldn't have implemented until probably 2015 or later, and we compressed it. And it's not just one system, I didn't even talk about that, but it's really 5 systems, because we in California have 3 local county eligibility systems that also have to interface, and we interface with those plus a statewide client index system. So all these systems are working together, and we're going through those bumps, and we're at the same time trying to add in renewal processes and change all the defects. So it will pass, but I don't think it will pass until 2015, and sometime in, hopefully in early to mid 2015, we'll get into more of a stable place.
Fully streamlined.
Yeah, I think I agree with what Toby said, that one of the great unknowns is what is going to be the volume of activity coming to the exchange in April through September. That's going to be people who are new to the state, changes in life, events, blah, 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 open up a special enrollment period for them. We may have some precedent for that, based upon the history, but we still have kind of an unknown about how much that volume is going to be. The other volume question is how much hand-holding do current enrollees need from Covered California, or how much do we turn over to the plans and say, call the plan, you're enrolled with them, they should be able to deal with that. So, those are the two sort of volume questions in the interim that, to the extent that those volumes are low, I think it provides space to focus on the Medicaid issues, which are not subject to an open enrollment, closed enrollment, windows. They are every day, every time. Toby's point about the architecture, we have an elaborate architecture. For those who don't know, it's kind of analogous to what the federal government is doing with the in its relationship with states. When the federal government gets somebody who's eligible for Medicaid, you have to hand that case off to the state where it's recorded and maintained. In California, we have 3 local computer systems that in various counties support the ongoing eligibility for those folks. And so we have to cover California, the joint website. If somebody applies there, the case has got to be handed up to the county. That process is working. but I think that it needs improvement. It needs to be, make sure that it's reliable, that the automatic matches are done as much as possible so that you limit it to the minimum, the number of touches you have to have for that person. And so I think there's a lot to improve. And I think, you're right, Toby. I think we should look forward to having it in good enough shape to make the open enrollment work this fall, but by sometime in 2015, I think we'll be in much better shape.
Yeah, and I should have clarified, I think that, especially as it relates to covered California, those applying for advanced premium tax credits, I think it will by the next open enrollment. I think for Medi-Cal, could take longer, and so because there are so many additional changes beyond the ones, given we have so many systems that we're working with.
Thank you. So my part two on the commercial side is around the networks. So Juan, I think you made a good argument for why narrow networks are have many desirable features, and I would be inclined to agree that they're here to stay. Clearly, there are big issues around consumers being able to have transparency, people being able to understand who is in their network, choose in a quick and efficient way to get there. And I guess, David, you may want to chime in on this as well. But the question is, can that quickly be resolved, or is there going to be enough churn in the design of the networks layered on top of the presentation of those issues that there's going to continue to be some, what I would guess is pretty significant uncertainty in people's minds about what the right choice is given their provider relations or preferences?
Yeah, I guess I can start there. My own sense is we're a ways to go before the issues of who's in the network, who's out are clear. Mm-hmm. We have anecdotes inside our own building when people are calling, members are calling saying, okay, I want to sign up. I'm looking for, Dr. Jones or Dr. Smith. Our own customer service folks do errors, make errors in pulling which. So they say what product is brand new at the beginning of the year. So there's people on new products, not just the Exchange IFP product. It's a unique product. So we've had instances of people giving the wrong information. And so then it blows up. There's a whole lot of anecdotes going on in terms of just the information. So the data we flow to Covered California isn't getting put up cleanly. Our own data is complicated. Our own people make errors. Some of this is also just the throughput, the number of phone calls coming in. So folks don't have the time to say, hang on, let me get this right. So I think this fall, because the enrollment process is going to be so much more condensed, I think we're going to face, we ourselves have a lot of preparation work to do way better this fall than we have this January and February for our own customers, right? So there's no doubt that's could have been better. We absolutely want to make it better the fall. The problem is it's so much more condensed, right? And my own sense is there's still going to be a big bunch of folks wanting to buy. Mm-hmm. And so we have to fix our systems, we're also trying to educate. There's a whole lot of education that has to happen with providers. We have a whole bunch, we renegotiated 60,000 documents. Many providers don't remember signing the darn document. And so I have had instances of someone saying, no, we don't take this. So we go through the paper file, find the thing, fax it to the doctor. Dr. Jones, is that you? Yeah, I'll be darned. I did sign it. Right? And so it's all that kind of stuff. It's just complicated.
Yeah, it is.
And time will fix it. So.
Anything else on that, or shall we?
Well, I hate the litany of complications. He was just talking about one of the 11 plans. Okay, so this idea of merging directories across 11 plans in Covered California to be able to tell somebody Dr. Smith is up, in the EPO of Blue Shield and in Anthem and, the following plans. That's a challenge that hasn't been done before. We're getting last I heard, we were getting close. So I'm optimistic that it will get in shape and get the attention it needs, because it is essential, particularly for the open enrollment drill. If you want to achieve the goal of, informed consumers moving with their feet, you don't get that unless you have the information at their fingertips.
Thanks. Okay. Let's start over there. Got a lot of hands, so we'll move as quick as we can.
Hi, I'm Richard Pitts. I'm a physician, also CEO of a large public safety net hospital in the second most poverty-stricken area in the United States. And currently we get 50% of our costs reimbursed by Medi-Cal. And with new people coming in, I know you get 100% for 2 years, then 90% for 2 years. With LIP, DISH going away, it's created substantial budgetary issues for us. We've also seen an uptick, excuse me, in the specialty services requested by Medi-Cal patients because there is a dramatic shortage of physicians in our area, and the governor also wants his realignment money back. So it's a real squeeze for us. So my question to you is, do you see Medi-Cal paying differential rates to areas that are impacted like ours, to try to entice, number one, simply physicians and perhaps better quality physicians to come into the area?
Well, let me take it more first on the macro level. I mean, I think that goes back to the point. So assuming you're an Inland Empire, is that fair to say? Okay. That, we have managed care plans, and so our plans, that this gets to the same macro discussion, is that our plans they need to ensure access within the system, so they look at ways to bring in providers, and that's different than what at state level. That's why we've driven policy differently, and our plans pay differently, and plans are going to look at how they bring in specialists and to meet that, as well as, I hope, looking at alternative ways, whether it's through telemedicine or other approaches. Now, public hospitals, as you know, it's a whole different story in terms of, we can debate the 50% of the cost, piece, but there are multiple sources. DISH is going down, but it's not going away. There's also, we have a lot of waiver funding that goes to our public hospitals. So there's a lot of different pieces of the equation that will continue to be essential. We as an administration have made it essential that we're going to put a strong focus on preserving the safety net system. And that means looking at what's the realignment funding, state funding that has gone for indigent care will be there to the extent it's needed. If there isn't money that comes in from the expansion of the Medi-Cal program. To the extent your hospital or others are seeing more Medi-Cal lives and receiving more revenue through Medi-Cal, there isn't as much need for the state funding, because you're getting your costs covered under Medi-Cal, and as you said, for many of these at 100% and then going down to 90%, coupled with the continued DISH at a lower level, but DISH will stay there, as well as funding under the waiver. So we have to continue to see that the bottom line, as I said on a big level, is the safety net is essential for our program over the long haul. And we have to look at ways to bring on additional providers, and that it's going to be both. I think it's going to be at plans having to look at ways that they pay as well as how they deliver care differently.
My name is Larry Wellickson. I used to be a practicing physician in Orange County. I'm now the CEO of the Society of Hospital Medicine. I want to just mention to Juan that my son had a individual Blue Shield policy with a high deductible, and through Covered California, he's got a better product and paying less money. So it's at least working for one person. I want to talk a little bit about...
Thank you for that. First one I've heard in a bit, but yes, thank you.
A little bit about consumer choice. So if we're going to have narrow networks, that we're going to have to provide the consumer with the information they need to make a choice. And I think that cost is a little bit more transparent. You can see what the premium is, although a little bit like buying a car, you don't see the total cost of ownership until you figure out what your deductible and your co-payment's going to do for you. But I'm a little bit intrigued by what David started to talk about providing some data on quality. And I hope it's going to be more than 2 stars in front of one plan and 4 stars in front of another plan. Is there any plan to get down to the level of data that consumers care about? So if your wife is pregnant, you might care about the C-section rate of a particular provider. For some people, it's, can I get a primary care physician? For other people, it's how long do you need to wait to get an appointment if you're a new patient? That's their definition of quality. For some people, it's, can I get a parking space near my doctor? So, when we get away from this, it worries me that we've provided over the years this macro kind of thing that there's 3 stars in front of it. And are we going to get down to, in narrow networks, something where people can say, I want this doctor because I know this about them, or this hospital because I know this about that.
Is
You
that
want
me?
to try?
I think that, for a couple of things. One is that the example of the quality measures that I showed today here are a start. They're the first step. There was a lot of controversy and angst, and if you follow the Covered California board meetings, a lot of public hand-wringing around what to do around quality, primarily because not all of the plans who were signed up had data that was relevant. Is the data relevant for that plan if it's something that was measured in 2013? You know, do you put it up as a measure of that plan in 2014 when it's maybe a different network, or maybe it's not, you know, maybe it's changed. So what there is this sort of these CAP scores on kind of administrative process that can be consistently provided for 9 out of the 11 plans, and that was as good as could be done. It was also thought that the changes in the nature of the plans between 13 to 14 wouldn't affect those scores so much as more quality scores. For example, the usual HEDIS kind of measures about vaccination rates and how soon somebody with, you know, I can't rattle off a bunch of them, but they really have to do with, for the population in that plan, what kind of responses are for particular medical conditions, you know, how many pregnant women what's the onset of prenatal care for pregnant women in the plan, that kind of thing. Those measures are going to be available through Covered California at the point when we can get consistent data across the plans that's relevant to the plans that are being offered. And I think that is the plan to do that. In terms of provider network, again, there was great dissatisfaction within Covered California and on the board that we don't have up a directory that is active and current and accurate about the networks that are being presented. Right now, people have to rely on the plan, and the data is available. You can call up, if you're thinking about a Blue Shield bronze plan, you can call Blue Shield and find out if your doctor that you care about is there. But that's a second best solution to being able to do that in the course of your application on the Covered California website. I think people are working hard to make that happen, and it's a high priority, and I think it does express that desire to make sure that the consumer is armed with all the information they can be.
Yeah, and if I could just to add to that, the real difficulty, because the underlying part of your question is, can you compare your IFP, your individual exchange population, the clinical quality, or even the HEDIS-like or STAR-like quality, in other words, the perception of folks in that product to your full or other networks? Problem, of course, is this is the baseline year, and we started, normally when you start a year, you already have all the people signed up. It's kind of much more organized. So we're probably a year, maybe 18 months away from having real data that looks back that allows us. So the simple answer to your question is the quality, true quality, anything that we can designate that I would say is going to actually answer your question and prove it, we're probably 18 months away from having a chance at it.
Okay, thanks. I think we're going to go over here, and we're probably going to have time for maybe 1 or 2 after that. So,
Hi, my name is Ray Raven. I'm a managing partner of a 5-man orthopedic group in Burbank, and I'm an MBA from UC Irvine as well. I have been a huge proponent of Obamacare and Covered California, and I often spent moments in my office talking to patients about it, how good it's going to be and how it's not the end of the world, especially for my very conservative base of patients up there. I had a few patients who asked me about the program, and I referred them only to find out when they tried to come and see me after signing up that I wasn't in the network. And you can imagine how embarrassing that was for me. So much that I'm really at a loss for what to tell these patients. This relates to the issue about transparency and the narrow network. It looks to me like something's being done to limit access to a certain degree, which is really the opposite of what I thought this was all about. All 5 doctors in the office are providers for Blue Shield, Blue Cross, Health Net, and only 2 doctors in the office are on the network. And we all do different things. We're hand surgeons, adult reconstructions, foot and ankle. And when we called to try to figure out what was going on, there were really no solutions to the problem. And I'd like you to talk about that.
Thank you. So Juan, probably that's you.
I'm
but
guessing that's for me.
I'm guessing that you might want to take that
Yeah,
sort of
so
up a level.
Right, so
again,
I guess the key is a couple things, right? Individually, I could have, if you give me your card, I can look into figuring out who in your group is in and who isn't. I can't help on Health Net, Blue Cross, et cetera. So I'm not sure if anybody from there is here and they could handle that, but we can follow up. The key is we sent documents out for signature to every individual doctor. So it could be that some of you in your group signed and some didn't, but I guarantee you I'll look into the detail and we can figure it out.
Okay, do you have one up here?
Hi, I'm Jan Frades. I teach at Cal State Long Beach Health Administration Program. This is a question for Toby. I was encouraged to hear you say that you're looking into new ways of working with FQHCs. We have this perverse incentive for FQHCs with the prospective payment system it's just one of the many ways that we've tried to shore up the safety net with stopgap measures that then become embedded in the system and so are awfully hard to unravel. But the things that you mentioned, the group visits, the e-consults, home-based care, telephone visits, telemedicine, all of these things are really quite well established in the private practice community, especially in the larger systems like Kaiser, like HealthCare Partners. How is the department looking to transfer or facilitate the transfer of some of this expertise from the private sector to the community health centers?
Well, I think it starts with the payment structure and working with our clinics on trying to figure out a way that they're comfortable of moving away from a cost-based reimbursement per visit to a more bundled payment approach where they then have the incentive to provide care differently. Now, that's easier said than done. Then it gets to the infrastructure building and working, and we're looking at ways to work with some of the more progressive or advanced community health centers that might have the infrastructure in place that haven't been able to leverage it given the perverse incentives, as use those as testing grounds to then expand on a more global basis. But it's going to take, this is, it's when you have, close to, 1,000 community health centers throughout the state, a long-standing system that has been essential for providing, just as with our public hospitals, providing an important safety net system, a third of our visits. But moving it in this direction is going to take time, but it's something that we and they want to advance.
Thank you.
Yeah, hi, Mark Cormany again. I'm a broker. This is for Juan. 2 questions. First, whose idea was it to have a network where people living in Marin couldn't go see doctors in San Francisco? And then second, I do all market segments. Is there a strategy to help alleviate ultimately the amount of small groups that are going to be renewing in December? I know you guys don't have the resource. I mean, fourth quarter was a mess for you guys with new group enrollments, people that changed plans, ID cards, admin, just it was a mess. So is there an exit strategy to get these groups off of December, because it's too high volume for me, and it's certainly, I would imagine, has to be too high volume for you and all the other carriers. So those are my two questions.
Yeah, so nice to have such easy ones. So I'll go to the second one first. Yeah, we're trying to do something about the December renewals. I don't head up our sales team, so I can try and get someone to connect with you on it, but I don't know, so I don't have a conclusion on it. I don't know what we're doing there. But clearly, we want to try and do. Ultimately, there's a goal to change that. Yeah. In terms of like the maroon question, that gets at the EPO. And so the problem was, it's one of those, it's just a function of it, right? So this is one reason why we've sold almost no one in the EPO, is because the members have to go to that county, and even if it's just over the bridge to go from Marin to San Francisco, it doesn't work, right? And
is that a covered California rule?
No, it's ours. It's completely just how we built it, right? And it was one of those, it's a little bit of an unintended consequence of it. Part of it is the folks that live in Marin, because typically you don't see folks, like, for example, in Contra Costa, they don't go through the Caldecott Tunnel to go from, John Muir, Contra Costa into Alameda and vice versa. And so we didn't expect that it would be an issue. Well, it turned out to be an issue, right? And it was, it surprised me, frankly, but we're trying to work on it.
Okay, we're going so quickly that we'll take one last question here, and then we'll tie it up.
Hi, my name is Jim Cubelos. I'm a statistician with CalOptima, the local health authority. And my interest is in how well we can insure everyone who is uninsured in California. I'm looking at the CBO's report and forecast for the United States that we're going to decrease our number of uninsured from 57 million to 31 million, which is a drop of 26 million. Now, what do you see in the for California from the standpoint of Blue Shield and Covered California in terms of how many uninsured we have now and how many we will have, say, in 10 years?
So a question about the remaining uninsured. Does anybody want to take that?
I can talk in just general, not the specifics of uninsured, but the key here for us is we're, it's a robust marketplace, 13 plans. We're all trying to, it's very important for us, right? So that there's, for me, it's important that there's marketplace forces that kind of drive what you're doing. We have a chance to augment our market share. We're a California-only company. So that's why we're so aggressively pushing forward. So the key here is we want to, and part of our mission is we want every single person covered, whether it's with us or somebody else. So the key is that's what we're trying to do. I think that we're on the right path overall, right? The kind of the demand for coverage that we've seen so far, the successive number of people signing up, the augmentation of Medicaid. I mean, all these things are actually working, I think, as intended. The question, though, and I think it's the crux of your question, how long before we really get the vast majority of, I think I've heard something like 7 million uninsured in California. How long before we get them all?
Well, never, because 2 million of them are undocumented. So let's just be clear about that.
So it's 5 that we're targeting. So I think it's years, but clearly it's kind of moving the needle is the important part in my mind.
Yeah, I mean, I do think it's worth noting for some of the policy design reasons that we heard about this morning that the Affordable Care Act is indeed intended to greatly expand coverage, but is not universal coverage and never will be in its current design, certainly in a place like California. And I think even among the people who are eligible for it, even fairly optimistic scenarios suggest that we might get 4 to 5 million people who were uninsured covered, while the remainder would stay out of the market for a whole host of reasons: documentation status, affordability criteria. They'd get an exemption from the mandate, and just some people are really hard to reach, and this is not their top priority. Okay, I promised that was the last one. It is 4:30. Thank you all, and thanks so much to our panelists.